I'm the Director of Academic Affairs of Korean Society of Lipid and Atherosclerosis. So it is very honor to me to be here for the presentation. So also I really want to further collaboration between Korea and Vietnam. Today's my topic is gender and sex difference in cardiovascular risk factors. You can see here this is the Korean data. This slide showed the sex difference in the instance of the myocardial infarction and stroke according to the age in male and female patients. You can see here the peak instance in male is observed between their 50 and 70. After 70, the instance of myocardial infarction and stroke decreased. However, in the female patients, their instance of myocardial infarction and stroke continuously increased by aging. Age is the most well-known risk factor for cardiovascular disease. If we calculate their contribution to the cardiovascular disease, in men, the aging effect is about 20%. However, in women, their impact on the cardiovascular risk is about 40%. This increased risk in elderly women may be mainly due to the lower level of estrogen. Estrogen in women play a significant role in cardiovascular protection. Estrogen induced angiogenesis and inhibit fibrosis, also improve endothelial cell function. So after menopause, this cardiovascular protective role of estrogen significantly decreased. So increased inflammation, oxidative stress, and sympathetic activity caused high blood pressure. Also, the estrogen involved in the fat distribution. After menopause, the woman's fat usually located in the subcutaneous area. However, after menopause, the woman's fat moved to the central area. We know that central obesity is more vulnerable to the cardiovascular risk. So this increased visceral obesity is associated with increased insulin resistance and more prevalent diabetes. So it is very important the lifetime exposure to the endogenous estrogen. You can see here women with early menopause show that higher risk of acute myocardial infarction. From the Framingham Heart Study, we know that traditional risk factors like hypertension, diabetes, obesity, smoking, and so on. After 50, there is a significantly increased arterial stiffness. So systolic blood pressure increased and diastolic blood pressure decreased. This phenomenon is very similar between men and women. However, in the elderly woman, this increased pulse pressure is more vulnerable to the heart function and morphology. In this study showed that increased pulse pressure more effectively induced LVH and LV diastolic dysfunction, implication for the development of HFpEF in elderly women. The risk of diabetes is more significant in women compared to men. Women with diabetes is about 50% higher cardiovascular risk compared to the men with diabetes. In our study, we showed that in heart failure cohort data, in men, diabetes was not associated with patient prognosis. However, in women with diabetes showed poor heart failure survival compared to the patient without diabetes. Smoking also a very important risk factor, especially for young women. You can see here, in women with smoking, usually show the earlier onset of acute myocardial infarction compared to the men. Because of more prevalent central obesity in men compared to women, the obesity risk for the cardiovascular event is slightly higher in men compared to women. Usually men show the central obesity, however in women usually have some more abundant fat in subcutaneous area and the hip, arm and legs. However, after menopause, the woman's body shape is changed to the like of men. The women with lower level of estrogen usually show the higher prevalence of central obesity like men. You can see here visceral fat area is wider in the postmenopausal woman compared to pre or perimenopausal woman. So risk of blood pressure is very similar between men and women. However, in elderly women, the pulse pressure is more influential to the cardiac function and morphology. And the obesity risk is slightly higher in men because of higher prevalence of central obesity. I wanted to emphasize the risk of smoking and diabetes is more significant in women compared to men. So we should focus on these high-risk people, especially women with diabetes or smoking, and we provide more stronger preventive treatment strategy. About 15 to 20 patients with acute myocardial infarction, they had no other cardiovascular risk factors. In this patient, we also think about the non-traditional risk factors, emotional stress, depression, or socio-economic factors. All these non-traditional risk factors play an important role. Their impact more significant in women compared to men. Chronic inflammation induced by rheumatic disease or autoimmune disease is a main factor for the progression of atherosclerosis. So you can see here the prevalence of this chronic inflammatory condition. The prevalence of this disease are significantly higher in women compared to men. So we also think about these chronic inflammation-inducing conditions in women. Another important risk factor is women-specific risk factors. Polycystic ovarian syndrome is a well-known risk factor for cardiovascular disease, or pregnancy-associated hypertension or diabetes. The complications, placenta rupture or the low birth weight, and the number of parity is also important risk factors for cardiovascular disease in women. The mechanism is some complex. So these factors, weight gain, last system activation, insulin resistance, and so on, these factors may affect women with multiple pregnancies. This Swedish study with large population showed that more than 4 times of pregnancy in women showed a higher cardiovascular risk even after childbirth at their later life. In Korea, there is a working group. They investigate the characteristics and prognosis of Korean women who underwent invasive coronary angiography. So more than 10 years of registry collection, now more than 4,000 of patients' data was collected. This data also showed that the increased number of pregnancy was significantly associated with cardiac target organ damage like coronary disease or LVH and LV diastolic dysfunction. We know that we usually ask the patients who went to the cardiology clinic with chest pain, do you have any risk factors like hypertension, diabetes, smoking? But we usually do not ask her about their history of associated with pregnancy. Did you experience any preeclampsia during your pregnancy? Or how many children do you have? We usually do not ask her. However, this data showed that the traditional risk factor, the cardiovascular risk, increased 2 times. But we know that preeclampsia is also very similar. Findings showed that their risk is about 2 times. This information is very important because this is a very important risk factor for cardiovascular risk even in elderly women. So traditional risk factor is very important. However, non-traditional risk factors like chronic inflammatory conditions, autoimmune disease, or rheumatic disease, and the other non-traditional risk factors, the emotional stress, socioeconomic status, and the other one is reproductive factors. The pregnancy numbers, preeclampsia, pregnancy-induced hypertension and diabetes. Also, these factors are very important determining women's cardiovascular health. This is my take-home messages. The estrogen decline in menopausal women is associated with their cardiovascular risk. Among traditional risk factors, diabetes and smoking is a more significant risk factor in women compared to men. And we should know about the non-traditional risk factors and sex-specific reproductive factors because these factors are very important in the determination of women's cardiovascular health. So I usually recommend you to try to obtain this information during your routine clinical practice. Thank you very much.